Good evening, class. Tonight we're going to talk about chest tube assessment and management. Prior to class you were assigned some YouTube videos and some modules from Atrium University, so I hope you all had a chance to take a look at that. We're going to review a couple of those modules tonight, and we're going to break up into groups afterwards tonight, and we're going to do a case method. Prior to that, we're going to review the atrium drainage system. So just to get started, we're going to talk about our objectives for tonight. We're going to identify indications for chest tube insertion. So why do we need them? What's the purpose of them? How do you know if your patient might need them? We want to also analyze the chest tube drainage system for maintenance and complications. And we're going to review that objective when we look at our atrium drainage collection. So before we get started, I just want to give both of you some handouts. Okay, so there's your outline. You're welcome. You're welcome. So if you can just take a quick look at it, this is what we're going to do, an overview of tonight's class. So our objectives, we want to do a review of Atrium University. We're going to talk about patient education, documentation. We're going to review the drainage collection system, take a look at the theoretical framework that is the purpose of tonight's class, and then our case study is on the bottom, and we'll do that later on when we break into our groups. But prior to talking about patient education, I just want to go back and review a couple of the modules that you had to do on Atrium University before class.
Normally, the thoracic cavity is a closed space. Within this space, negative pressure surrounds each lung and pulls the lung toward the chest wall to keep it inflated. When an incision is made in the chest for surgery, or when a stabbing or gunshot occurs, this negative pressure instantly becomes positive and the lung begins to collapse toward the mediastinum. If air or fluid remains in the pleural space between the lung and the chest wall, the lung will not be able to expand fully. Thus, one or more chest tubes are used to remove air or fluid from the chest so the lung can re-expand and the negative pressure can be re-established. Chest tubes are also needed after cardiac surgery to drain fluid from the pericardial sac and reduce the risk of fluid buildup that could lead to cardiac tamponade. Whether the tubes are in the pleural space or in the mediastinum, they are connected by tubing to a chest drain. Next, we'll discuss the three chambers that make up a chest drain. Traditional chest drains have three chambers: a collection chamber, a water seal, and a suction control. In other modules, you'll learn about technological advances that, in some cases, replace these chambers with mechanical valves. The collection chamber is closest to the patient. The patient tubing connects to the drain here and fluid accumulates in this chamber. You'll want to monitor the fluid's appearance. Postoperatively, you'll see bloody drainage that becomes darker over the first 12 to 24 hours. Sterosanguinous drainage is pink to straw-colored and may occur postoperatively. And fluid from a pleural effusion may be clear to cloudy and, in the case of infection, even pus-like. Here's more information about the collection chamber.
The first collection chamber column is...
I'm actually going to skip over this part because we're going to talk about this.
The water seal chamber is in the middle of the drain. It allows air to leave the chest and prevents air from going back into the chest through the tube. Think of it like a straw in a glass of chocolate milk. You can blow bubbles through it, but when you suck on the straw, you pull up fluid instead of air. Since air can only go one way, you could call this a one-way valve. You'll want to monitor this water seal chamber to see if air is bubbling through the fluid in the chamber. Here's how.
Continuous bubbling observed in the water seal will confirm a persistent air leak in either the patient's thoracic cavity or possible tube connections. Intermittent bubbling with gentle float-ball oscillation will confirm the presence of an intermittent air leak. And no bubbling with minimal float-ball oscillation at the bottom of the water seal indicates that no air leak is present. Bubbling from right to left in the air leak monitor must be present to confirm an active air leak.
If there's no bubbling and the chest tube is in the pleural space, you should check to see if the water level moves up and down with respirations, reflecting pressure changes in the pleural space. This is called tidling, and if present, tells you the system is functioning properly. When the lung is fully inflated, however, this motion may not be visible.
Changes in intrathoracic pressure can be determined by observing the level of the blue tint water and float ball in the calibrated water seal column.
The suction control chamber is the third chamber on the left side of a traditional drain. Here's more about how it works.
The volume and height of water in the suction control chamber is what safely controls the amount of suction pressure provided to the patient.
Remember, it's the level of water that determines the amount of negative pressure transmitted to the patient, not the setting on the vacuum regulator. If you can remember the 9 assessment steps in this module, you won't miss anything when you're caring for patients with chest drainage. To make the steps easy to remember, we'll use colorful photographs that will jog your memory. We'll start at the patient and work our way down and through the drain. The first step is to check the dressing. Make sure it's dry and occlusive. Dressings around chest tubes do not need to be routinely changed. Next, check the tubing to see if there are any dependent loops. You know the kind that make drainage go uphill to get into the collection chamber. If you see a dependent loop, remove it by coiling the tubing on the bed for gravity drainage, the same way you would do with tubing for a Foley catheter. Good research has shown that there's no need to strip or milk chest tubes to enhance drainage. These maneuvers can expose the patient to dangerously high negative pressures in the chest that can damage lung tissue or the heart, depending on the tube's location. Now you can start checking the unit. First, you come to the collection chamber where you'll check the drainage. Note the amount and type of fluid. You can mark the level right on the front of the drain. Next, check for bubbling in the water seal chamber. Bubbling indicates air is entering the system and being vented out of this chamber. If there is no bubbling in the water seal and the patient has a pleural tube, look to see if the water level moves up and down with breathing. Called tidling, that's normal and reflects the intrapleural pressure changes that occur with normal breathing. Now check the level of the water in both the water seal chamber and the suction control chamber, since water will evaporate from the chest drain more quickly if there's bubbling in one or both of these chambers. Add fluid as needed. Adjust the vacuum source so that there is gentle bubbling in the suction control chamber. Once bubbles appear, excess negativity is vented. Vigorous bubbling does not increase the negative pressure, but it does make a lot of noise and hasten evaporation. Finally, follow the tubing from the drain across the floor and to the vacuum source, which is usually a regulator on the wall. This tubing should remain open so air can leave the system. It can easily get pinched by the wheels of equipment at the bedside.
Okay, and one last one, just a review of chest tube.
Chest
Of the
tubes are
trocar.
also called thoracic catheters, and they come in a variety of different sizes. Like an endotracheal tube, there are tiny tubes for infants and much larger ones for adults. But in chest tubes, The size is also determined by what is being removed from the chest. If it's only air, a much smaller tube can be used compared to draining blood or other fluid, where a much larger tube will be necessary. Tubes come in different configurations. They can be curved or straight. They can be made of polyvinyl chloride or silicone plastic, and they can be coated or non-coated. A thin heparin coating helps reduce the risk of clots forming in the tube and decreases friction.
Okay, so what questions do you have so far from the video? Mary, any questions? Everything made sense to you?
It seems to make sense. Are these, how many different types of chest tubes? I know that they kind of use these, but there's other types, right? Like there's
There
other-
are other types, so it depends on your organization, where you're working, and what kind of products they have, but these are two very common types that you'll probably see out in practice, so we'll review those tonight. Do you have any questions?
How long do people usually have a chest tube in?
It all depends how much they're draining. So if they're draining a lot, they're going to leave those chest tubes in until the drainage is usually less than 100 mLs a day, or doctor's preference. So they can stay in for a couple days, up to weeks. Sometimes patients go home with them and they change them over to a portable mini atrium. This looks very similar to this. So, good questions. We're going to review patient education right now. So when you have a patient that has a chest tube, couple important factors up here that we have to keep in mind. So you want to encourage them to use their incentive spirometer. You don't want them getting atelectasis because their lungs are already at risk for infection, complications. So definitely they should be doing their incentive spirometer hourly. We also want to encourage them to splint, either with a pillow or a blanket or something, put it next to them while they're coughing so that pressure on there won't hurt as much, because chest tubes are difficult plastic tubes that are inside. They're hard. I do have one here and I'll pass it around. So it is a lot of pain when you have a chest tube, so splinting with coughing is important. We also want to encourage our patients to take pain medications as needed, just to help with the use of effective coughing, and also when they're going to be ambulating. And that's our final one. Ambulation is extremely important with chest tubes. You need to get them up, get them moving. They should be doing at least 3 to 4 walks throughout a shift, not a shift, but when they're awake throughout the day, they should be walking. So walk, 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 can never hurt. And then next I want to talk about documentation. So initially when the chest tube was first placed, we want to document on the atrium drainage collection. We want to do it at least hourly. You want to know what kind of drainage is coming out. Is it serous, serosang? Is there pus? So you need to document what kind of drainage. And we'll talk about where we're documenting on the atrium. And then once your drainage has come to slow down, we can then document every 4 hours. So you want to mark the atrium drainage system with a permanent marker. You're going to mark it with date, time, and initials. So what you would do is you would come over here or wherever your drainage has ended. You're going to draw a little line. Say if it's next to 60, we'll draw a line with a permanent marker. We're going to write the date and the time, and then we'll put our initials. So important to pass along and report how much drainage you had out in your shift. So I do actually have a trocar here that you guys can take a quick look at, and then you can see how hard it is. And this is actually what they use to puncture the patient with. And then this is a common size. This is a 28 French. So as you saw in the Atrium University, it said usually a 28 French or a 32 French is a common chest tube size for a patient of normal stature.
How far does it go in?
It does, so it goes in pretty far. So these will be in, usually it's into here, and you'll just see this hanging out. So it's usually in there pretty far. So you can imagine if you have that much of plastic or silicone in you, if you're coughing, coughing and sometimes it's rubbing up on other anatomy there, it's definitely difficult. So splinting, pain medication, and central spirometer.
I don't see a whole lot, but like, they don't usually do it at the bedside unless
They
it's-
do, they can.
But don't they usually go down? Like,
No,
No.
they're kind of barbaric and they're not usually very pleasant to get them in, but you will be assisting either trauma or the surgeon with it, putting them in. So, yeah, they do numb them up, but still, it's a quick jab. It's not too pleasant. So, if you guys are okay with that, we're gonna go ahead and we're gonna talk about, we have two different atrium drainage collections. Depends on doctor, surgeon's preference. So the video was showing you ocean, so think ocean, wet, that's the one that bubbles. And then there's also dry, a dry oasis, which is quiet. They both do the same function. So I guess I'm gonna review the dry one right now because they did talk about the ocean, the wet one. So this is a dry atrium collection. So take note, we have A, B, C, D, and E. So A, it's always gonna come preset with your negative pressure. So typical negative interthoracic pressure that they have set is -20. If you wanna change it, there's a dial on the side, you can change it to -30, but your standard is usually -20 or whatever your doctor's order is at. So first thing, I always check your pressures, set correct. When it comes, it actually comes with a pre-filled normal saline, a little like 10 cc syringe. You're going to go ahead and you're gonna drop it. You're gonna drop it into here and it's gonna fill this up. So we always want it, as you can see, there's a 0 there. You always want it at the 2 centimeter mark, and that is where we're gonna check for an air leak. So next here is going to be, there's a ball there. So when this is in the patient, and you'll remember from the video it said to check titling. So titling will be up and down. So as I'm breathing in and out, that ball should be going up and down, up and down. There is a valve, and I know it's hard to see, but you guys can see this. I'll let you play with them. There's a valve up here, so if our ball gets stuck all the way up here, we can push this, and that ball is actually to release, prevent the high pressure from building up. So if that's up there, you can press it. That ball will come all the way down to where you want it. One thing, if your ball is stuck up there, it does not tidal, stays at the bottom, might be an idea to maybe grab a chest x-ray, maybe your lung has re-expanded. So that would be one reason for not tidling. Another reason would be if the chest tube is maybe clogged with blood clots or mucus, if there's pus. So always a good idea to notify the doctor if you can't get titling to happen. You can always troubleshoot and get a whole new atrium set up as well. So we talked about checking for air leaks down here. So to check for an air leak, you're gonna have your patient take a deep breath. You wanna see titling up and down. So in and out, have them cough. You want a forceful cough. It is difficult. A lot of times they'll give you a little, you need a big, hard, strong cough, best you can. If you see bubbling that comes from the left to the right, I guess it would be your right to left, that's gonna indicate that there's an air leak. So again, you wanna backtrack all the way up to the patient, check around there, make sure they didn't disconnect your drainage collection from your chest tube. Sometimes that does happen and you just wanna get it back together quick. So if there's a bubble that comes in there, sometimes they're intermittent, meaning they'll only happen when they cough, or there's continuous, and you'll know as soon as you walk in that room, you'll just hear like, you'll hear it. And D is left for the drainage collections system, where we're going to measure what's coming out. So again, we want to know, is it serous sanguinous, is it pussy, if they have infection. So, and we're going to want to document initially hourly, then we can go to every 4 hours. And then always a good reminder when you're changing for your oncoming shift, if you're somewhere around here, you might want to be nice and set up a new atrium for them. So the video also spoke about suction. So whether you want your patient on suction or just to water seal, depending on the doctor's orders. So with this, suction's gonna look a little bit different. Here's our suction up here. So we're gonna go ahead and put our suction tubing to that. When there's suction, this is gonna pop out on the side here. It's gonna look like an accordion. So that's how I know my atrium is to suction, because I'm gonna have the accordion out. If the doctor wants it to water seal, that means they're off suction. It's gonna look like that. You won't see my accordion in there. And the way to tell with this one, if you remember from the video, is, you can tell right here, this is where the bubbling's gonna be. So if I'm hooked up to suction, so my suction tubing would go on this. This is my regulator, and remember what they said on the video. It's not how much bubbling is going on here, it's all on what's hooked up on the wall as far as your suction, your pressure for your suction. And then this will be bubbling in here. You don't need it vigorous because you're gonna drive your patient nuts because they are loud, so just a nice gentle bubbling for that. Same way, you're gonna have titling in here, and you're gonna check for your air leak down here, so bubble coming across, and then you're gonna record your amount of drainage there. You guys okay with this? And also, it does have that release valve on the top if your pressure is high and you can't get titling. Okay. So just quick again, I know the video talked about this, we're gonna talk about the 9 key steps to assessing drainage system. So there, as you see, there's 9 steps. So if you can remember these working from the patient to the chest tube, hopefully you'll have enough knowledge and you won't miss anything. So always check the dressing. You wanna make sure it's clean, dry. Think of the girl in her little pretty white dress there. If there's bloody drainage, you probably have a problem. Maybe you have a clog chest tube, maybe some blood clots. No dependent loops, so your loops should not be dependent, meaning so that gravity can let that drainage come out into your drainage collection. No stripping or milking of the chest tube, so evidence has shown that it does no good for the patient. So, and it's also out of nurse's scope of practice, so we don't strip or milk our tubes. You want to check your drainage. I think we talked about that. Sarah saying. Check for bubbling. Should not be vigorous. It should be gentle. And check for titling. Again, Mary, can you tell me what it means if the ball is stuck at the top?
You have to release the pressure.
Okay, good. And then we want to check the level of the water. So when you have it hooked up to suction and it's continuously bubbling, it's going to evaporate over time. So you need to stop your suction, check, and if need be, you would add your water, either sterile water, sterile saline to it. And then we want to adjust the bubbling. We don't want it too vigorous. And we're going to check the tubing. Always make sure that your tubing is not clamped, that you don't have the bedside table rolled over it, because then you're going to collapse their lung, which we have seen before. So always make sure that your tubing is open. And I have a little activity for us to do next. So one problem that might happen with chest tubes is we might get crepitus. And can either of you tell me what crepitus is?
It's where you can feel like almost like fluid, right? You can actually feel the fluid in there.
Yeah, so it's actually air that's trapped in the subcutaneous layer of the skin. So, and they always say it feels like Rice Krispies, so now we're gonna demonstrate. So if you can just put your Rice Krispies, lay them flat in your bag, kind of spread them out. And then I want you, so what you do, so say we have a chest tube that's over on our side, we're gonna just start around there, we're gonna just use our fingers and we're gonna go around. And then you can work your way all the way up. You can always check up into the clavicles, so you can crack it and you can feel, that's what crepitus feels like, and it makes that sound too. So I've seen crepitus all the way up into the orbitals, I've seen it down into the scrotum. It's painful and it hurts. So one thing to remember with crepitus is we have to watch for tracheal deviation. That's a late finding, so if you're seeing, first you'll notice that they'll get nasally, they'll sound like a chipmunk. If you notice that, you really need to pay attention to their oxygen saturation. They'll complain of difficulty breathing, and hopefully you will catch that before a tracheal deviation occurs. So if you want to feel crepitus, that's what it feels like, Rice Krispies. So next I just want to move on to constructivism. So that was the theoretical foundation of what tonight's teaching strategies were. So flipped classroom and also case method. So constructivism actually involves several teaching strategies: problem-based learning, the flipped classroom, case method. It started in 1980s and 1990s after the approach of behaviorism was kind of criticized that it was an effective teaching strategy. So it was developed. The definition of it is searching for meaning. It also involves peer review, and grading's important with it. So instead of me standing up here giving you a grade, it will be positive or negative feedback from your peers. And then one of the founding fathers of constructivism was Lev Vygotsky. His work was known in social constructivism. I forgot what he did. He wanted to inculturate the learner in the learning environment, and the social environment allows for the learner to apply appropriate knowledge to solve problems. It's important because it helps to have the students interact with each other and come to a solution for the problem. However, there is a problem, or one of the criticisms of this approach is that not all learners might be on the same level, so some learners might be left behind with this approach. But for the most part, studies have shown that it is an effective way of a teaching strategy. So I want everybody to go ahead and break up into your pre-assigned groups that were posted. Okay. So I do have a case study up here for tonight. You're going to have 30 minutes that's left in class, so you're going to work on your case study, and I'm going to be around helping with any questions. If you guys finish your case study, I definitely want you to come up, play with the atriums here. If you want to pass around the trocar catheter, you can go ahead and do that. So our case study tonight is talking about a 40-year-old male patient that presents to the ED post-MVA with penetrating trauma to the chest. So think, we have a chest wound here. Patient's cyanotic, he's short of breath. His trachea is deviating to the right. That doesn't sound good. Vital signs are 98.4. His pulse is 124. His respiratory rate is 42. And BP is elevated at 162/94. So in your groups, I want you to go ahead, answer these 4 questions, and then you're going to go ahead and submit them tonight on D2L in your Dropbox. And then again, I'll be around. If you have any questions, let me know. If you're done, I want you to come up and take a look at the drainage collection systems before you leave, and then that's it. So have a good night.